Good evening once again. So we are very glad to here to have Dr. Ashima here. Dr. Ashima Mukhopadhyay, as you know, is a gynecological oncologist and a clinician scientist working in James Cook University Hospital and Newcastle University in UK and also CNCI Kolkata. And she obtained her MBBS from Medical College Kolkata and MD from AIIMS New Delhi with a gold medal. She had her specialty training in Obs Gynae UK and Gynecological Oncology, Northern Gynecological Oncology Center, MSc in Clinical Trials from London School of Hygiene and Tropical Medicine, and PhD from Faculty of Medicine, Medical Sciences, Newcastle University, and she was awarded Faculty Prize. Her key clinical and research interests include ovarian cancer, cytoreductive surgery, and targeted strategies, precision surgery, translational clinical research in gynecological cancers involving regulation of tumor and microenvironment by HRD status and therapeutic application of this knowledge in clinical settings, and also patient advocacy and cancer health inequality. So I would request Dr. Mukhopadhyay to please come on stage, and the topic for today is setting up academia-industry collaboration in India for cancer diagnostics and research and the way forward. Please, Dr. Mukhopadhyay.
So I will go back. That's right. So I think, good evening, everybody. And I have to thank Suraksha team and my students, of course, Shubhajit Chayantuni and Dr. Somnath Chatterjee for inviting me. And actually, I want to say inviting me, making us part of his team. Because I was induced to Suraksha, of course, by my students, because I have trained them for last 4 and 5 years in primary cultures, in HRD, in PARP and everything, and I'm getting old. So I didn't think that I could do it again with another 5 years with anybody else. So like parents follow their children, I'm following my children too. So anyway, so they were in Suraksha, and then they gave a good news that they're going to set up an R&D facility. Great news. And of course, I have been working towards developing a PARP inhibitor in Newcastle and HRD testing and a lot of stuff. And I'm going to talk a little bit about how my association with industry has been for a very long time, and then how I think I could translate those principles while building up this collaboration, which is going to be a very important one because we do have some unmet needs. So today I am representing, or this is actually my first talk as being formally appointed as the director of Kolkata Gynae Oncology Group, that being scientific industrial research organization certified by Government of India. So a little bit of background about Kolkata Gynae Oncology Group. As you can see, I'm still a very proud Bong, and I couldn't do without my Kolkata name. Even I do represent India internationally. So I was thinking loud that whether at the beginning I should actually have a name of Indigo. It's like India Gynae Oncology Group, and then ask Indigo to sponsor us. But then, okay, well, the better half of Rasgulla took, I think, the care of me, and it became Colgo TRG. Anyway, the T is translational, TALL T is a translational and trials research group. And I got induced to form this group by compulsion and compassion because I met Professor Bookman, Amit, Ted Trimble, Dr. Narayan, all these people who kind of give me a flavor of what a gynae cancer intergroup is. And I felt quite embarrassed when for the first time I was in Lisbon as an observer, that out of this big world and so many people getting chance to be included in trial, which of course increases their survival, there is no Indian representation. I was the sole one sitting in the back of that hall, and I was just thinking, well, I mean, I really felt very embarrassed and ashamed. And I think, as I say, feeling ashamed, and that's something else. But then, of course, I had, collaboration from 3 institutes. At that time in Kolkata, Tata Medical Center, I was there. Then it was CNCI, where I just worked until a few months back, but I'm still a mentor to my trainees, and Thakurpukur, where I'm a mentor to their trainees as well. So anyway, we formed a collaboration with the clinicians, and at that point of time in Kolkata, we had less clinicians and more scientists participating in the group, the motto being that we're going to translate science into appropriate clinical trials which are needed for our women. And it had to be affordable. And while doing that, I have always felt that there are certain things we are always lacking behind, and one of them is to have a very good diagnostic standard which can match the international standards so that the patients are even included. And then once they're included in the trial, all the trial specifics now are included molecular biology and diagnostics, and we still have a challenge in actually delivering them to the best. To the standard which mandates us. I don't want to be representing like 5% of some low middle income country. I want to have an equal footage in the international arena without being saying that our women are low middle income country. We should be equal. So anyway, we had clinicians and scientists, and we set up this platform. And of course, this is the first annual meeting we held in style before we were actually formally a full member of GCIG, and you can see Dr. Bookman sitting in the middle because he has been the guiding force. And then we had Professor Hacker, Dr. Mandal is here, Kailash is standing on the back with Rahul, Professor Tripathi, Professor Biman Chakraborty, of course, and dignitaries from ICMR and all. So that was a great launch we had. But then, of course, we were only 3 centers. I think over the time we have learned, of course, COVID came in between, but the main idea was to create a generation of young researchers so that we can train them how to do clinical trials and research in gynecological cancers, which is my field. And of course, I'm very happy to see that now Colgo has actually become Indigo in a way, because it's spread its wing outside Kolkata. We have centers from north, we have centers from east and south, and big institutions. I'm an alumni of All India Institute of Medical Science, a proud alumni, so getting Madam and Ames was no big deal for me. But to see that centers from Vellore and other big centers in India joining us is a great pleasure. Aster is the first organization to be officially signing a contract as an institution, as a partnering institution to Kolkata Gynae Group. And then, of course, we have a lot of clinical institutes. The beauty of Kolkata, of British Raj, I don't know whatever they think, but they thought, but they've done a really good job of the clinical institutes, and 5 kilometers, 10 kilometers around of that, we have the Center for Excellences, where some of the Nobel Prizes have been won, even for the work that has been done over the years. So we are very privileged to have a collective scientific faculty roaming around us and giving us intellectual input. We have international partners. As I mentioned, that I'm also an alumni for London School of Hygiene and Newcastle, so forming a clinical trial unit. They were obviously my mentors and official partners. And now also we have centers from hopefully Nepal and Bangladesh and other countries who will be joining us, so we can actually represent our region and our regional problems into an international platform. And IGCS, International Gynae Cancer Society, also has been a great partner, because not only giving us the international the fellowship program to Kolkata. We started again in Kolkata with this program representing India, but of course, a chance to integrate these young people with the GCIG Young Investigator Program in the future. And we are developing international gynae cancer nursing program, because a lot of trials require research nurses. and nurse-led infrastructure. So this International Gynae Cancer Society also is becoming possibly a strategic partner to our society. And as I say, only this last year, we have now obtained a zero status, which is a scientific industrial research organization status with Government of India certification. That means that we are an independent research organization and we can obtain grants and funds. And I think as a director stepping in, I think this is going to be my prime responsibility to make it grow and build up into possibly an institution in the future. Of course, I cannot do without the help of you and others, and this is where I am. So this is just a very little flavor of just one cancer I'm starting, ovarian cancer, which is my passion. And we have presented this slide, but on the left-hand side, you can see that's a usual journey a cancer patient would have in a high-risk setting, good surgery, then testing, BRCA testing, diagnostics. We have HRD testing to decide your treatment, then you have PARP inhibitors or bevacizumab, then you treat recurrence, again diagnostics, and then some other bits. But then, of course, everything is challenged in a low-resource setting. Low resource is not necessarily less money. It can be also less information. It can also be less knowledge. So it's a combination of everything. And so basically, then you need to have an alternative strategy to make affordable cancer care and diagnostics. And that is where I think a platform like this, academia-industry collaboration, because you bring the scientific ideation and all, but then you don't know the implementation skills or how to make it sustainable. So I think that is where some of the government institutions fail, that we reach to a point, but we never know how to make it self-sustainable and even grow further. So that's where I think, again, as I say, our Kolkata Gynae Oncology approach, on the right-hand side of the column, a lot of the studies that we are doing, whether it's in HIPEC or a nurse-led counseling or biobanking, which is the key for our gynae oncology translational studies or PARP inhibitor studies and all, I think we have held a lot of meaningful collaborations, and I think the latest one and the lasting one should be Suraksha, for a lot of good reasons, which I'm going to talk about in a minute. So first is we have a database, we have all the studies or the trials we are doing right now. These are our own indigenous studies, and we're hoping for international participation. But again, to reach the standard where in my study I can comfortably invite another country to join me, I need my standards to be up first. And that is where somewhere we need to admit our limitations. You know, sometimes you can do big things from a small organization, but it's very important not to do small things from a big organization. And you know, so therefore, to understand your limitation and therefore collaborate with each other, that's important. I know this by heart because my training was in discovery or development of PARP inhibitors, and we knew during my lifetime when we delivered the science, but that at some point of time we had to give the intellectual property of the drug to pharma. It used to be Agaron and then Pfizer, but then they took it to the FDA approval. As a university, we were in no position, whatever we have done for 20 years, to have the skills to take a drug to an FDA approval and for patients' use. So that is why it is important that we know where we stand and we collaborate appropriately with industry. And there's no shame. I think sometimes I feel there is a hush-hush about, oh, an academic institution of this stature or standard should not be talking or collaborating with an industry. I think it's very wrong, and it's possibly a backdated feeling. So these are the studies that we are taking part internationally, and I have put this slide deliberately because every time and again, whether we are trying to recruit patients for a sentinel node assessment, or whether we need to do a radiotherapy QA, or the Rainbow study is looking into molecular classification-driven treatment strategy in endometrial cancer, but to compete with no lesser standards to my international fellows, countries, and researchers, we really need to have a dedicated radiology, oncopathology, molecular diagnostics, And I think, you know, very few centers in India in a government setup has that capability. Maybe ACTRIC has, maybe an isolated pocket has. But the patients, all countries' patients, they just don't go to 2 or 3 centers. So we need a top-down approach or a grassroots to the top approach, and only a diagnostic chain with a far-reach approach who is committed with an R&D wing, who is committed with maybe developing a research development wing and working a top-down approach could possibly deliver at least the basic level diagnostic standard which is required in our country and of course in our trials. So this is a concept driven by Kolkata Gynae Oncology Group. We call ROCK Group concept. Not that we are a rock band, but its ambition is to develop a regional ovarian cancer center. K is Kolkata. And I'm persuading my Nepal friends to make it Kathmandu as well. So anyway, so the idea is that every patient should have a clinical MDT, a trial MDT, and a precision medicine MDT. And then only you are doing a justice because you have a good head of people deciding, you know the molecular biology, you know the trials which are available, because even participating in a trial, as we know from Interlace and others, uplifts the standards of your standard of care. So that is where we should be doing a lot of MDT for ovarian cancer and other cancers in an integrated platform. And to run an MDT, you are again reliant on very high quality pathology and radiology. And that is where this is another area I see of integration, even if it's in a virtual, but to have that standardized approach so that we as an academician can also maybe discuss with our pathology and radiology colleagues in a diagnostic center that, hey, we want it this way. Or maybe the GCIG criteria is mandating this thing for now we need to do 3 mm slice or 1 mm slice or whatever for our trials. So could you please do it while you are providing a diagnostic service for the patient? Because now I find I have to do it twice, everything. Somebody has done something somewhere, paid some money. I need to put the patient into the trial. I need to do it again to meet the standards. So why not include in the beginning? Biospecimen collection and a biobank. Again, it is not possible nowadays to do any translational clinical trial without a proper biobank. When I started in Newcastle, biobank used to be just taking some samples and putting, in an Excel sheet in a box and putting into a fridge, and I used to be the biobank manager from Gateshead. But then we have realized that the systems can be so sophisticated for annotation, for blinding, for auditing, quality checks, and that is again another area we are collaborating with Suraksha to develop our biobank, because I have worked with institutes, many institutes in Kolkata, cancer institutes, but there are some limitations sometimes which needs you, whether it's TCS, whether it's Suraksha, doesn't matter, but it needs somebody with that, how to put it, the word, that vision of organizing in that scale, who is going to be monitored by CAP standards or NABL standards continuously with a hammer on or a stick on to deliver the job on time and in style. And unless you can integrate with them, you can't deliver a standard of an international biobank, because we are going for ISO certification soon. This is the last few slides. This is my background, developing an HRD assay. And there are so many other HRD assays available, the genomic assays, the SCAR assays. Everybody has their pros and cons and application in clinical trials. But of course, the assay which I developed and subsequently has been taken on by other groups in different formats is the cheapest. Is the cheapest of all the HRD assays which is available, but the problem is that it is requires live cell, at least the version I did, and therefore it was never translatable for proper pragmatic use. And this is where, again, combined with R&D and all, we can bring the test cost down, we can integrate into a biomarker, an assay for our setup. Of course, we will undergo a validation study, and that is why we are writing a joint proposal with industry. And Government of India is very, very supportive now to go into a PPP model or academia-industry collaboration. They have opened a cell called BIRAC in DBT in order to foster this sort of collaborative grant applications so that we develop and they take it forward. I'm blessed, I'm very happy, but I think it is important that we are okay, or we are able to reach out to the wider audience with the drug, with a PARP inhibitor for indicated uses and the HRD assay. And that is why we're forming an academia-industry collaboration, but again, a wider one. It's not only me. I have colleagues from Manipal, scientists. I have other people involved. I have pathologists from UK. Hopefully pathologists from here too, as well, in the due time, and radiology, all of us together to develop an academia-industry collaboration. It may not work. Many things do not work, but sometimes the mistakes that you learn when it does not work takes you to the next lead. And that is why nothing is a failure. I think, it's a venture. We join hands together to go forward. If it works, it's great. If it doesn't work, we take the next battle. This is another project. I have been very thankful to Dr. Chatterjee that this is a project. Of course, I learned this craft, I would say, from Professor Nirja Batla. She's kind of put a seed in my brain when I was very young. And even if I do PARP or BRCA, I can never come out of that screening thing. So anyway, I love tea. I am addict. Tea. I have headaches if I don't have tea. So once in sitting in Margaret's Tea Hope and that brilliant garden, I was thinking of these workers, and I thought about doing a screening study. So it was a point of care HPV testing. Now trying to do this testing in the hills, I was fraught with organizational issues, and there was Dr. Suraksha Chatterjee, very graceful in offering his office space in Suraksha for my staff to be working there. My two young girls over there, they're sitting in the back, to house the gene expert machine there, to have their faculty without charging anything, doing these tests for me, tests for us, I would say, and helping us directly or indirectly. So I am very, very thankful to you as an organization and as the director of an organization, and to acknowledge the favor, because we are going to go for screening 100,000 women in the region, and I cannot do this without your support. It's so important to deliver a report with a CAP accredited standard, because it protects me while I'm in UK, while I'm in India, while all of us are running around that, hey, this report is generated with style. And I think it's very important that we do understand that even in research, we could do anything in our own lab, but to take it to a level where it is credible, you again need to partner with the right hands. So I think this last slide, bridging the gap and unmet need, as I said, I have left Amit to speak on it when he comes, or a question answer scenario. But I was amazed when I attended this consensus statement conference. It was the first time for me sitting over there. And then I think there was an entire section on pathology and radiology standards and what you have to do in order to be able to participate in a GCIG clinical trial. And I was really scared that how I am going to deliver now that I am there. I'm presenting India in that forum. I feel like I'm an Olympian going there, representing my country, and I don't have these standards. So I told, again, Shubhajit and Shayantuni, that could we have a center for excellence for gynae pathology somewhere? We need to do this. It's a pride of our country. I am not going to run to AIMS or Trek. It's not possible. I need something in my own city. And I'm so very grateful that you have come up with this idea to create an oncopathology center for excellence, because we, as a scientific organization, my pathologist from UK, my radiologist from UK, will all help to develop the standards which are needed, if it's like mentoring support or whichever is needed. I cannot talk about others, but at least the gynae pathology which is required for my trials and for my patients, we will deliver together with biobanking. And I think this is the need of to have a service which is integrated with research, development, embedded in clinical trials, and most importantly, it is self-sustainable. I have worked in many, many organizations where our existence was dependent on grant applications. And if you don't get grants, like COVID came, all the grants shunted in other direction, then you sink. So you really need some sustainability, maybe diagnostic or something or the other, which provides you with the stability so that, if your grants did not come from government, you can still carry on, at least from the diagnostic scenario. So with this, I would end, because I am going to be followed by some of the luminaries and dignitaries in this field of gynecological cancer. Sometimes I don't know whether I'm daydreaming. If I see them walking or standing in front of me and even talking to me, I'm getting used to day by day. But these are the people who, we have been reading all their articles. We know every evidence we talk to practice have come from their studies. So I am really honored that Michael, Amit, Kailash and Madam Nirja, they have come all the way to attend our meeting, and hopefully they will, tell a little bit about why it is so important that we do our diagnostics right in clinical trials and otherwise. And thank you again for giving us this opportunity. Thank you.